I'm going to present a case. A 62 years old gentleman, Mr. Ram, a resident of Nagakoil, who is auto driver by occupation, belonging to lower socio-economic scale, came with chief complaint of ulcer in the inner aspect of left cheek for past 3 months, which was incidence in onset and initially smaller in size and gradually increased in size, attained 4x3 cm. And not responding to a course of antibiotics and associated with pain while eating. History of smoking BD for 15 years, history of tobacco chewing for 15 years, history of using quid for 10 years, 1 to 2 per day, and he will be taking overnight and during working also he will take, commonly kept in lower buccal sulcus. General physical examination. Patient was examined in well-lit room with adequate privacy after obtaining consent. The patient was conscious, cooperative and well oriented to time, place and person and time. The patient is moderately built and well nourished. BMI is 24, Karnafi scale is 90%, no pallor, no icterus, no cyanosis, no clubbing, no pedalaemia, no generalized lymphadenopathy except cervical lymphadenopathy. Vitals, pulse rate is 76 beats per minute. Blood pressure is 135 over 95 mm of Hg. Respiratory rate is 19 breaths per minute. Temperature is 37 degrees Celsius. Examination of oral cavity. The patient was examined in well-lit room in sitting posture after obtaining consent. On inspection, poor orodental hygiene, adequate mouth opening, no trismus, nicotine stain over the tooth and gums, no halitosis, no loss of tooth, normal tongue, palate and floor, arches look normal. An ulceroproliferative growth over the left buccal mucosa of size 4x3 cm in size and irregular in shape, extending 1 cm from angle of mouth and posteriorly from 4 cm from retromolar area, superiorly from 3 cm from gingivo-buccal sulcus, inferior from 3 cm from mandibulo-gingivo-buccal sulcus. Floor of the ulcer is presence of slough. Edge of the ulcer is raised and everted, no discharge from the lesion and retromolar area is normal. On palpation, all inspectory findings are confirmed by palpation, presence of tenderness over the lesion, ulceroproliferative growth of size 4x3 cm present over the left buccal mucosa, induration is felt at base, ulcer do not touch and bleed, bidigital palpation of mandible is normal, tongue, palate and normal, tongue, palate, gums are normal. Lymph node examination, a single mobile hard nodule of size 2x3 cm in right cervical region at level 2 lymph node, upper deep cervical lymph node, no other palpable lymph node. Diagnosis, ulceroproliferative growth in left buccal mucosa and presence of left cervical lymphadenopathy, probably carcinoma of left buccal mucosa, TNM staging T3N1M0. Investigation, I will confirm by wedge biopsy and FN.
You can wait. So your diagnosis is carcinoma of the left buccal mucosa. Okay. What are the points in favor of your diagnosis?
Sir, first point is age factor, sir. It's above 62 years, sir. Most commonly in CA buccal will happen above 50 years, sir. Second, male is a male, sir. Third, most commonly male will be affected than female. Third is history of using tobacco, quid and smoking, sir. For past 15 years, sir. So he's a chronic tobacco user, sir. Next, on inspection, ulceroproliferative growth, sir, which is 4x3 cm, sir.
Apart from tobacco and other predisposing factors, what are the other predisposing factors for oral malignancy?
Sir, other predisposing factors are tobacco, alcohol, quid, and sharp tooth.
6S.
6S. Sharp tooth, spicy food, syphilis, sepsis, spirit alcohol, submucous fibrosis.
Where do you include the tobacco?
Sir?
Where do you include this tobacco? It's not
tobacco. Using quid.
One more you can add. In our part you call it shampoo. Shampoo is also, it also starts with S.
Shampoo.
It's not available here. Okay. So we content with 6S plus tobacco. Okay. What are the other predisposing factors? Other pre-malignant conditions or predisposing factors?
Sir, other pre-malignant conditions are
Poor oral hygiene, I agree.
Poor oral hygiene, sir.
Yes.
Erythroplakia, leukoplakia, erythroleukoplakia, submucous fibrosis, oral lichen planus. Other HPV infection also can occur, sir.
HPV infection.
Yes, sir.
HPV.
HPV, sir.
HPV.
Yes, sir.
Human papillomavirus.
sir.
HPV.
HPV,
Yes,
sir.
yes. Any other virus?
HPV. TB, sir.
Any other virus?
Virus. Epstein-Barr virus.
Epstein-Barr virus.
Epstein-Barr virus.
Epstein-Barr virus. Okay. Then, in your clinical examination,
Sir,
what was the mode of onset of this?
sir,
lesion?
it started with a small ulcer, sir. The patient came with a small ulcer, sir. Over a short duration of time, the ulcer proliferated, sir.
It is not an area where you get a sharp tooth or bite or anything. It is an area near the angle of
commonly
mouth.
keep it
Yes.
He will keep
You used to keep the squid there. Yes.
sir.
Finally, how did he notice it?
Sir, on daily basis, while eating, he got irritated, sir. Sometimes, initially he thought it was like an aphthous ulcer, the normal heat boil ulcer, but it progressed, sir. After a course of antibiotics, so it was there, sir. So he came to
Whether
diagnosis.
there was any other complaint like bleeding,
Initially there was bleeding, sir, but
pain,
first while eating only the pain was there, sir.
excessive salivation,
No excessive salivation, sir. No excessive salivation, sir.
and also whether he is able to speak without any
Yes,
difficulty.
he can able to speak, sir.
Some patients having oral cavity, especially tongue malignancy, they will have these symptoms also.
Okay.
So excessive salivation is because they can't swallow the
It's a
saliva.
foreign body, so excessive salivation will occur.
Can occur, yes.
And irritation also causes the excess salivation.
What do you understand by ankylosing?
Ankylosing. Tongue in floor of the mouth.
These are all structures inside the mouth.
What do you mean by ankylosing?
Tongue tied.
Inability to move.
It occurs in malignancy.
Okay.
The restricted
Ankylosis.
mobility of the tongue.
Ankylosis of the ankle, your joints, etc. Ankylosing when the
Inability to
muscles of the tongue are infiltrated,
Infiltrated.
and also there are how many type of muscles are there in the tongue?
There are two types of intrinsic muscle and extrinsic.
Intrinsic and extrinsic. What are the extrinsic muscles?
Extrinsic. Genioglossus, genioglossus, styloglossus,
Hyoglossus.
hyoglossus, palatogloss.
When these muscles get infiltrated, the tongue movement will be restricted. Understand? Okay.
Increased salivation you see in tongue malignancy.
And smaller minor salivary glands tumors.
A patient sitting in the OP department constantly spitting. You can suspect. See a tongue.
What else did you examine in the oral cavity? Because a complete oral cavity examination is mandatory in this case.
Yes, sir.
You have to check for other skip lesions, other
primary,
Yes.
other primary.
Yeah.
Any synchronous
So
tumor.
what all did you look for in the oral cavity?
Sir, first I looked for the trismus, sir. It is more than 3 finger breadth, sir.
Yeah, what is trismus?
Trismus is inability to open the mouth, sir.
What are the causes of trismus?
Sir, submucosal fibrosis, carcinoma buccal mucosa, innervation of tumor into pterygoid and
Apart from oral cavity. Apart from oral
may cause
cavity.
any cyst.
Hey, apart from oral cavity, what are the other conditions you have a trismus?
Dislocation of temporomandibular. Tetanus.
Yes. Any normal condition producing trismus?
Even caries.
Any normal condition? I don't know whether you have.
Quincy.
Yeah, no. Normal condition. I don't know. What age are you? How old are you?
Sir, 23 years, sir.
Your wisdom tooth has erupted? Have your wisdom tooth?
Wisdom tooth.
Not, sir. Not yet, sir.
So you will, when it happens, that is a normal condition which will produce trismus.
Okay.
Eruption of wisdom tooth.
And
Okay.
caries tooth.
Yeah, caries
Caries
tooth.
Molar.
Oh yes.
Local.
It can happen. Okay. So, right. How will you? Yeah. Ajith.
See, you said in your history that the patient came with with an ulcer of 4 by 3 centimeters, 4 into 3 centimeters.
Yes.
I genuinely doubt whether any person walking into the OP will come and tell you that, sir, I have a 4 by 3 centimeter ulcer. That will not happen. Okay. Now, so can you come over here and describe this particular ulcer?
Sir, there is an 4 cross 3 centimeter, sir, and ulceroproliferative growth. Ulceroproliferative growth, sir, and base is indurated, and floor is.
See, where is the ulcer?
Indurated, sir. Floor level is, sir, is the presence of slough material.
See, you make an examination as though you are presenting. Okay. First is sight and extend.
It is extended from 1 centimeter from the angle of mouth and 4 centimeter from retromolar area, sir, and 3 centimeter and 3 centimeter from gingivo and maxillary and gingivo, maxillary and mandibular gingivo buccal circus.
Okay.
Circus, sir.
Then, what next? What next?
Shape is irregular, sir. Irregular shape.
What is the size?
4 cross 3 centimeter, sir.
Shape.
Shape is irregular.
What next? You continue.
Okay, sir. And edge of the ulcer is raised and everted, sir.
Raised and everted.
Raised and everted, sir.
Raised and everted.
Raised and everted, sir.
Where can you show me in the picture where it is raised and everted?
This side.
Can you make a comment on the floor?
Sir, in the floor there is presence of granulation tissue and irregular slough.
Granulation tissue, your diagnosis is malignancy, no? Then how come there is granulation tissue happens only when an ulcer heals? Can you expect a malignancy to heal?
No.
Then what is it?
Unhealthy tissue.
Huh?
Unhealthy tissue.
It's unhealthy tissue.
Unhealthy
It's malignant tissue. That is a word that is given in books. Okay, what else can you find? What else do you expect to find in the floor? Have a closer look. Is there any slough?
Lightly.
Any bleeding points?
No, sir. No bleeding.
Any clots?
No, sir.
Any raw areas?
Surrounding the skin.
Any raw area in the floor? Especially it is a proliferating thing, no? The floor
Yes,
is getting proliferated. Any raw areas? Because it is close
Yes.
to the teeth, there is a possibility of the tissue getting sliced off by the teeth, and then a raw area. Have a closer look. Is there any?
No, here.
Because you never mentioned these things in your presentation.
I didn't see.
What about the margins of this ulcer?
Margins are regular and
What is the meaning of regular margins?
it's continuous with
Is it inspection, no?
inspection.
Come and show me the margin. Where is the margin and how is it? What is the color? That is the edge, no?
This, sir. This
What is the margin?
is a flow. It is a junction between this skin and normal skin and ulcer, sir.
Skin. Where is it?
Sir, skin is other ulcer and normal tissues.
What is it? What is its color?
It's pink colors.
Where I can't see anything pink over there. Don't fall down, media.
Black.
See, can you expect a margin to happen? When do you expect a margin to occur?
Sir, when is growth is extending.
See, it happens only in a healing ulcer. It's a fibrotic ring. Okay, you cannot expect a margin here in a malignant ulcer.
Okay.
Okay, so in palpation, if you palpate this particular ulcer, what all things should be palpated apart from the findings in inspection?
On palpation.
What about, can you comment on the surrounding area? What changes can happen in the surrounding area in this particular ulcer?
Can any erythroplakia, leukoplakia patches can be
Exactly.
seen.
Anything else?
Bleeding points. Any
Bleeding points, no.
Indurations.
Induration inspection, I'm asking.
Inspection, sir.
Can you expect dilated veins to be occurring?
It can be, sir, for it's all growth. It can be high vascular.
Any other ulcers can you expect in the surrounding area?
Yes, sir. Another
But in your
primary.
presentation, you never mentioned all those things.
Another tumor can be there.
There can be
Another lesion.
Yes, in palpation, you palpate for what?
Sir, I palpated for the for base, sir. Base is indurated or not, sir?
Can you demonstrate the palpation mockingly for the edge in this particular thing?
It just
Mockingly, you have to do it like this,
bidigitally one.
and then you will have to. You got a raised and eversion, no?
Yes, sir.
You'll have to demonstrate how the raising and eversion in palpation is.
Sir.
For example, if I am demonstrating a flight taking off, it goes like this,
Okay.
like that.
Sir, by the one index and thumb.
You can start from here. This is the edge. Okay. Start from here, palpating. Hey, give me the mic. Okay. You palpate. How do you palpate? You palpate means you do it this way. Like this you palpate. Okay. You have your right hand, no? Yes, you can do like this. Suppose an aeroplane is taking off, it goes like this. Everted edge. Raised and everted. My dear, it goes like this, and then there is a point where the normal skin finishes off, and then you can find that it's getting raised and then it's getting everted like this. Like this. Like this. Like this. It goes like this and that goes like this. This is eversion. Okay.
You are going down and
So now you said it is, what is the diagnosis?
Sir, CA buccal mucosa, sir.
Why did you say it is carcinoma? How did you come to the conclusion that it is
Sir,
carcinoma?
by history, he's a chronic tobacco user, sir. Next, followed by growth.
You can pick one point, the most important point,
Age.
most important point in your diagnosis. In any ulcer, dash is the most important thing which is diagnostic.
Induration.
No.
Edge and the
It is the edge.
edge.
Edge is the edge is the diagnostic. You classify ulcers based on edge, no?
Okay.
Suppose I say that the eversion happens only in this particular spot and the rest it is sloping edge. What will be your diagnosis? Eversion is there only in this particular area, small area. The rest of the area it is sloping edge. What will be your diagnosis?
Healing, a normal healing ulcer, which is
A
turns.
particular part is just getting everted.
Then that part alone going for malignancy.
That part is malignancy and the rest is something else.
Normal apical ulcer.
No, my dear. If any small part is everted, that eversion will carry significance.
Okay, sir.
And the diagnosis will go like that. Suppose I say this is a tuberculous ulcer. Am I right or wrong? Am I right or wrong? This ulcer is a tuberculous ulcer.
It can be
Can it be this ulcer? Can it be?
tuberculosis. Under manage. Under manage.
So I am wrong, no? Can this be a syphilitic ulcer? Yes or no?
Syphilitic, no.
Yes or no? No. Why?
Punch out.
Exactly. Now you checked for lymph nodes, no?
Yes, sir.
You mentioned it as a.
Level
You
two
mentioned the word nodule. I think it is in this case.
it is node only. Don't say node. Go to the forward.
Mobile hard nodule.
Node.
Node.
Don't say nodule.
What else do you want to examine and find out when you get a lymph node? You said it is a single lymph node. You measured this size. What are the other features which you want to know from the lymph node?
Consistency. Hard
Yes.
inconsistency, I mentioned.
Yes, okay, fine. What else?
Mated or non-mated lymph node. Single or
That's a single say.
Single
it
I
is
mentioned.
method. What else?
size.
You want to know whether it is tender or not. What is the significance of
The tender means it can be inflammatory condition can cause lymphatic.
suppose this node was tender?
Due to inflammation can.
What is the relationship of that tender node to that particular ulcer?
No, it's non-malignant.
Will it be non-malignant? It is hard, no? Hard indicates what?
Infiltration of tumor.
It is the tumor in. The tumor has spread. It is a metastatic node. Suppose it is tender also.
Nerve involvement. Any nerve can be
Nerve involvement, something else?
compression.
Some problem in the ulcer?
Infection, super infection of the ulcer.
Yes, exactly. Infection.
Super infection.
Now you want to know whether this particular node is fixed to surrounding structures. How do you know that?
By mobility. Sir.
Mobility. This is
sir.
mobile?
It's mobile, sir.
It's mobile. Okay. Okay. So you have come to a diagnosis. What is the next step?
Sir, next I will confirm the diagnosis by wedge biopsy.
And the biopsy report comes as squamous cell carcinoma.
Okay, sir. Wedge. See.
Oh,
Sir, ma'am, first I will anesthetize the areas, ma'am. Anesthetize the area, and with help, and we should keep an retractor. With retractor and
That
with help
procedure
of
and all don't know. No need.
we'll take a slice of
One point I expect.
incision.
How will you take that tissue, chunk of tissue?
With help of
Along with the normal tissue. you have to
along with the
take.
normal tissue. What?
That's why edge
Wedge
biopsy.
biopsy.
That's why you are taking in the. Why not in the center?
In there is presence of necrotic material in the center.
Good,
ma'am.
good.
And
So
peripheral-
you have to include the normal tissue also.
So, is there any other investigation
Sir, for
which is non-invasive,
on CECT will take, sir.
not imaging?
Image.
For a incision, for your wedge biopsy, you have to take the patient to the operation theater. You have to give anesthesia, etc. Isn't it?
Yes, sir.
In the bedside or in the OP, can you do any procedure to get
OP
a
procedure.
cytological diagnosis
FNS.
of the ulcer? You don't do FNS of ulcers.
The node.
FNS is no.
No,
Smear.
no. I want about the ulcer.
Smear, sir.
What smear? What is that smear called? What is that smear called? Not buccal smear.
Pap
You
smear.
can do it. Yeah.
Pap
Yes, sir.
smear.
Sir told. Imprint cytology. That is imprint cytology. Even you can do it. You can keep a glass slide over the ulcer and stain it and look it under microscope. You are
I
not
told it
sure.
is a non-invasive, no? Just put a slide, take the imprint, study under microscope.
FNSC you can take from the node.
Node.
Node you can take. Understand? So how will you proceed? What other
Treatment.
Sir, my treatment, I will be approaching by wide local excision of
Why
the.
can't you put the PowerPoint? Treatment.
Sir, wide local excision with the modified radical neck dissection with post-op.
So how much margin you have to give
Sir,
for wide local excision?
around the tumor 1 centimeter margin will give, sir.
So how far is this your ulcer from the angle of your mouth?
Angle of the mouth is 2 centimeters, sir. 1 centimeter.
So what happens if you do a wide excision there?
Angle of the mouth gone. Reconstruction with the flap will do, sir.
So how deep also, that is also important. What are the muscles in that area? How deep will you take? 1 centimeter or 2 centimeter means it should be a 3-dimensional excision. Everywhere you should get that 2 centimeter. If you take 2 centimeter, everywhere around the lesion you have to get 2 centimeter or 1 centimeter. So will you be able to excise your lesion, do a wide excision without compromising the muscles, skin, etc.? That is it perforating outside?
No, sir.
No. So a good clearance means at least 1 centimeter
Around
all around. all around. So you may have some muscles in the cheek.
Yes, sir. Facial muscle, buccinator muscle.
Buccinator muscle, yes. Which node is involved?
Sir, upper deep cervical or upper jugular-digastric node, sir.
Upper deep cervical.
Jugular-digastric.
Jugular-digastric. Yes. What about submental, submandibular?
It is also commonly can involve, sir.
No, in this patient,
case,
your
in your
patient.
case.
It is not palpable, sir.
Not possible. Okay. So will you be limiting your treatment with a wide excision alone, or will you combine it with some other
I'll
procedure?
combine it with neck dissection, sir.
What type of neck dissection?
Modified radical I can do, or suprahomoid dissection also I can do, sir.
Yeah.
When will you prefer supraoma?
Ma'am?
If the node, do a FNAC in the node. When will you prefer a supraoma?
Prophylactic also we can use, or diagnostic also we can.
You are not understanding my question. When will you do MRM, modified radical neck dissection, MRND, or prophylactic supraoma?
Clinically palpable lymph nodes are present, I'll do.
Do
Neck dissection.
MRND.
MRND.
Positive node MRND. Even in a negative N0, you have to do a supraoma.
Suprahomoid dissection.
Yesterday they told no? Prophylactic neck dissection. Supraoma had indicated.
Suprahomoid. N0 condition.
That's all I am asking.
For you prefer radiotherapy or chemotherapy in this?
Radio chemotherapy I'll prefer, sir. Both combined. It's advanced
You
stage.
prefer radio or chemo?
Both, sir.
What type of malignancy is this?
Sir, it's advanced cases,
Is it
sir.
adenocarcinoma or squamous cell?
Squamous cell carcinoma, sir.
Squamous cell carcinoma is more sensitive to what?
Radiotherapy. Okay, radiotherapy.
Radiotherapy. What all types of radiotherapy can be given?
Linear accelerated.
We are having
Brachytherapy,
linear
external beam
accelerator,
therapy.
Yeah, intralesional brachytherapy that can be given. If it is a very large tumor, you will have to do a mutilating surgery, isn't it? Before that, you can give radiotherapy. It's very sensitive, very sensitive. Okay. Did you examine the other, the contralateral neck?
Yes, it was normal, sir.
All normal. All normal. So you have said the oral hygiene is bad. There may be caries tooth. There may be other nodes. This node also may not be a positive node even. Understood. Okay. What is PMMF?
Sir, pectoris major myocutaneous flap, sir. It is an axial flap. It's used to cover the defect.
So it's a bulky muscle, isn't it?
Yes, sir.
It's a bulky muscle. When you have to compromise a very large area, only you will use this myocutaneous flap. Otherwise,
Deltopectoral.
either primary closure,
Or second, or the free flaps I will take.
rotation flap,
Rotation
flaps,
flap or
etc.
Narayana flap. A radial forum flap.
Okay. You got a lymph node in the upper neck.
Yes, sir.
How will you distinguish between a submandibular gland and this node?
Sir?
Submandibular gland, node and the gland.
Bidigital palpations.
Bidigital.
Palpations.
Bidigital or bimanual?
Bidigital, sir.
Bidigital.
Bidigital.
So you use two fingers, digits of two hands, or only single hand?
By two hands. Two hands.
I don't know what your teaching is, but when you use two fingers or fingers of two hands, you call it bimanual. Actually. You can palpate the Stenson's duct bidigitally of the same hand. But submandibular node and submandibular gland, actually our teaching is it is bimanual, because you cannot do it with the same hand. You have to keep one hand here. And what will be your finding if it is a gland? What will be your finding if it is a submandibular gland that is enlarged?
It will be a hard inconsistency.
If it is a
Gland is bimanually palpable.
Which part of the gland is palpable from the mouth?
Deep part.
So you confirm the diagnosis with an incision biopsy. What other investigations?
Sir, I will do FNAC of lymph node and CECT for staging of the tumor I will do, sir. Ultrasound in the bedside.
CCT of head and neck.
Head and neck and up to the lungs I will take, sir. For any distal metastasis can be there.
What is the use of CCT head?
Extension into the bone, the cortical bones, or head invasion to lower part of skull, facial bone involvement.